Yeah, thanks. And thank you for selecting our abstract as an oral in this conference. This is very exciting for us. So I'm representing the LIFE study team, which is actually a consortium of European, Mozambican, and Tanzanian collaborators. And we run a study next. Oh, I'm actually here, able to click myself. Yeah. So the background, basically, background information has been paved throughout the previous talks. The current prophylaxis regimens and neonatal ART procedures within the first weeks are currently still based on nevirapine regimens due to lack of toxicity or PK error that are increasing now. And also, we have heard that there is a switch to dolutegravir-based regimens based on high frequency on primary NNRTI resistances in adults and in infants older than 4 weeks. So we conducted a study called the LIFE study that was recruited between 2019 and July 2021. In Mozambique and Tanzania, and I'm going to show you only Mozambican data today, for example, where we used this regimen for those infants who were identified then at birth or later, starting with an AZT3TC nevirapine. And at this time, we had no dolutegravir, but we used the granular formulation of the lopinavir from week 4 and older. So briefly, this was what we did here. We actually recruited 4,014 HIV mothers and their children and randomized them into 2 arms. And this arm A, we actually performed birth test and treat procedures with the possibility to start immediate ART in those tested positive and provided enhanced prophylaxis, as this is universally done in Mozambique. In arm B, we collected specimens at birth at visit 1, however, started really testing according to the national algorithm then at week 4 with a delayed start of treatment, at least for those who were already infected at birth. So the primary purpose here was really to find the clinical outcome, which I'm not going to talk about today, but really about the resistance. We also had a smaller cohort then on 253 infants who were then longer-term follow-up for later HIV transmission analysis, and online, as those visits came up, we collected samples for the purpose of testing as much drug resistance as possible, and this is data I just want to show you now. So basically, our resistance testing was performed in Nuno Tavares' lab in Lisbon, in Portugal, used from virologic serum samples from mothers at the time, preferentially when the neonatal or infant HIV diagnosis was made. Also, we used mostly serum samples for neonatal genotypic resistance testing by Sanger sequences, and we used the Stanford algorithm. So we identified 205 mothers who had a viral load above 1,000 copies, and we had 117 HIV-infected infants through the course of this study. And of those, we were able then to receive available drug-resistant information from 78 mothers and 75 HIV-infected neonates and infants. And among those, we were able to really match 39 pairs, and matching was then defined that a resistance test between the mother and the infant was not more than 3 months apart, to really comment also on transmitted and acquired drug resistance mutations in this setting. Briefly about some characteristics. So age, high viral loads in mothers. Most mothers were actually on a dolutegravir-based regimen, 78%, and some still on an efavirenz. The timing of ART initiation, as you can see, that most mothers were actually diagnosed and started during pregnancy, and those were especially those who started on a dolutegravir-based regimen, as compared to those who were before pregnancy already infected and still on an efavirenz. And there were also 4 mothers who were then just detected at delivery. From the infant characteristics, you can see here this was the time of HIV diagnosis. 30.7% at birth, and then another 41% at week 4. However, within this week 4, about half of those infants were already retrospectively tested at birth as positive, but they were just diagnosed then at this time point. And then we had later rounds. There were 5 infants who were then also diagnosed at a much later time point there. So the age of the drug resistance test, and we used the first drug resistance test we could get from those infants. So for some, we got them at birth. The majority was at 4 weeks, then 12 weeks, and basically it went up to month 6 that we received this. And the regimens infants were exposed to at the time of drug resistance testing were either PMP, so the enhanced PMP azathioneuropy, or the tail with the nevirapine. 5 were still on the neonatal ART regimens, and the majority had already switched to the lopinavir granule regimen that included that they were previously exposed to nevirapine, either through PMP or neonatal regimens. So frequencies among mothers and infants on drug resistance mutations, so we did not find that many PI drug resistance mutations. The majority clearly was found for NNRTIs, so 57% in infants and 39% in mothers. Also NRTIs were significantly more often seen in infants as compared to mothers, and we had some few integrase inhibitor resistance situations. So overall, 46% of mothers, or 43% of mothers had any drug resistance mutation, and 61.3% of the infants. All viruses were subtype C as the dominant subtype in Mozambique. And what was of note is that we actually did identify so many NNRTI resistances, despite that most mothers just had started on a DTG-based regimen and never had been opposed to NNRTI treatments, indicating most likely that also these mothers were already infected with the primary NNRTI-resistant virus strain. So just looking now in the proportions of different drug resistance mutations, I mean, you find this classical 103 and the 181 from the NNRTI. The mutation 138 in the Stanford algorithm is affiliated to an RT situation here, and it is actually selected by ripivirine, etrovivirine, not that much from efavirenz. However, as we also heard, the 138A or K and Q is also affiliated to dolutegravir as an initiator of this resistance. So it might be that this high proportion here comes as a situation from mothers already transmitted throughout. We also found other integrase inhibitor mutations in children, especially accessories there. So if we looked into our matched pairs, we did find 19 mothers, so almost half of them who had drug resistance mutation, and another 20 mothers who had no drug resistance mutations. Of those, drug resistance mutations were transferred in roughly 79% of cases. 4 infants did not have any drug resistance mutation transmitted, which was a bit of a surprise to me, because I was always under the impression this might be close to 100%. And naturally, those who were born from mothers without drug resistance mutation did not have any transmitted resistances here. So those infants who had transmitted drug resistance, in almost half of them, they acquired further drug resistance mutations as compared to those who had no transmitted drug resistance mutations. Here we found pooled 29% of them who acquired, and I mean, due to sample size, we do not find any statistical significance here. However, would say this is a trend indicating that certainly transmitted drug resistance is a risk of further early multiple drug resistance approaches in the background of those treatments. And again, here you find the patterns of the transmitted versus the acquired drug resistance mutations that we detected. Again, the E138A might be affiliated rather to the integrase inhibitors and not to the NNRTIs. However, you can also appreciate that especially the 184V that was transmitted, but then also in a large proportion further accumulated the L74 against the abacavir as concern, indicates that those infants really in a very early age receive already or acquire multiple resistances that might affect treatment options in their life. And last but not least, we really wanted also to understand how much did this impact the clinics, and we looked into the viral loads in the first 4 weeks, and this is more or less a case series having only a limited amount of infants available who had a viral load done at birth and at week 4, and had also a drug resistance situation here. So in the baseline, high viral loads, you see higher viral loads in those without drug resistance mutations. This might be because of viral fitness. However, a bit to our surprise, we found a greater log reduction in those who had transmitted drug resistance mutations. However, 3 of them had the 138A, and nevirapine might not have impacted at this stage that much the problematic here. So in conclusions, half of all mothers with neonates who are infected have drug resistance mutations, and most of them transmit them to their infants. It seems like infants who have already a pre-existing primary resistance mutation have a higher risk of accumulating further drug resistance, suggesting impacts on further PMP and in brackets a little bit also ART efficacy situation. And as has been discussed also several times before, nevirapine-based PMP or neonatal ART regimens need to be revised, and there was a discussion of a 3TC dolutegravir substitution, and this that is, in my view, supported by our data here. So last but not least, thanks and acknowledgement to the team, the funders, the EDCTP Unit 8 and the DEZIS, the German Center for Infectious Disease. Some of investigators here also in this audience here from Mozambique as well as from the US, and thank you for your attention.